Dear colleagues, friends, and participants, I see that we still got 2 minutes to go, but I would like to welcome you from now to this very interesting conference that we have here today. I'll be just waiting for another 1 minute, and then we could start exactly on time in order to allow for all participants to come in. So good afternoon, everyone. So I believe that we can now start this session. My name is Cyrus Engerer. I'm a member of the European Parliament, and it is my great pleasure to welcome you all to the World AIDS Day high-level event entitled Closing Inequality Gaps for People Who Inject Drugs, Promoting Community-Led Responses for Rights-Based and People-Centered Health Services. My special thanks go to the Czech Presidency of the Council of the European Union for hosting this important event. And I would also like to recognize the co-organizers of today's event, UNODC, Aidsfonds, and UNAIDS. We really appreciate your continuing support for raising awareness on important inequalities squarely impacting on people's health and well-being. Indeed, the AIDS pandemic is not over, and more worrying, the world is not on track to end AIDS by 2030, one of the SDG commitments. This is because we failed to address the inequalities that drive the AIDS pandemic. We failed to put our political commitments behind the 2030 targets of ending AIDS, and we failed to ensure there is sufficient and sustainable financing, including for the critical work undertaken by communities and civil society organizations. So I look forward to today's discussion, where we will be reviewing the inequalities associated with injecting drug use in the European Union region, diving into effective responses, including from a policy viewpoint. We will start by the opening remarks of Mr. Jędryk Woborin, the National Drug Coordinator of the Czech Republic. We will then contextualize HIV/AIDS amongst people who use drugs with UNAIDS and UNODC. And we will then move into our panel discussion, which I will introduce after this first session. Finally, we will take questions and comments from the floor. To this regard, I would like to acknowledge the questions that were asked upon registration. The speakers will try as much as possible to address these in their interventions. If your question remains unanswered during the session, please feel free to reach out to the colleagues as indicated in the chat. But before handing the floor to the first speaker, I would like to present a short welcome video statement by the UNAIDS Executive Director, Winnie Bianima, followed by a video statement by Ms. Ghada Fathiwali, Executive Director of UNODC. So let's start with the video from the Executive Director of UNAIDS, Winnie Bianima.
To mark World AIDS Day, it is my great pleasure to welcome you to this event, Closing Inequality Gaps for People Who Inject Drugs, promoting community-led responses for rights-based and people-centered health services. I'd like to express my great appreciation to the Czech Presidency of the Council of the European Union for hosting this important dialogue. I'd like to thank the representatives from the Czech Republic, civil society, the European Parliament, the European Commission, the Netherlands, Spain, as well as UNODC for their participation in this event and for contributing to an enriching discussion within the context of the EU Global Health Strategy. Thank you.
We now will move to the next video, which is by Ms. Ghada Fathiwali, Executive Director of UNC.
The slogan for World AIDS Day this year, Equalize, is a call to action to make sure that our efforts to end the pandemic extend to every single person suffering and at risk. We need to reform laws, policies, and practices and tackle the inequalities that hold back the AIDS response. The UN Office on Drugs and Crime is committed to implementing the Global AIDS Strategy. Together with our partners at the UN Joint Programme on HIV/AIDS, we will continue to make every effort to magnify its impact on people, including people who use drugs and people in prisons. This World AIDS Day, let us put stigma and discrimination aside and leave no one behind in ending AIDS once and for all.
So after from the two of the co-organizers of this event, I would like to now introduce one of our hosts of today, Mr. Jandrik Voboril, who is the National Drug Coordinator of the Czech Republic, from the Office of the Government of the Czech Republic, to give us his opening remarks. The floor is yours.
Thank you, Chair. First, let me welcome all the participants on behalf of the Czech Presidency of the Council of the European Union. The thanks particularly belong to UNODC, UNAIDS, Aidsfonds. Welcome also the members of the European Commission, academia, and civil society, of course. And let me be not too formal and be frank and go to the point. Czech Republic policy, as it is in the program now, and as we trying to negotiate the council conclusions, is very much focusing on human rights and practical help of people who suffer with drug problem. HIV and hepatitis C is particular issue among the intravenous drug users, and millions of people are ill or are positive with this illness, often not unnecessarily. It's very much due to the stigma that allows to stop an access to treatment, or having zero or very little prevention. We also see unequal funding, lack of access to substitution treatment, which is big part of the prevention of HIVs, especially in the area where the HIV in Euro-Asian part is very visible, such as Russian Federation. And let me be frank, a lot of it is due to the stigma which is attached to a very harsh drug policies and prohibition. I think it is a time to rethink our policies and take the stigma away. It cannot be happening, it will not happen until we rethink the harsh policies, which sometimes or very often in many parts of the world actually put the whole drug scene in the hands of organized crime, which leads to enslaving women, sometimes children, making the situation with drug use being in a violent environment, and creating, most of the whole problem is creating a hidden population. People feel people feel that they have to be afraid to ask for help, and even if the help is there, they still feel they should be hiding, or they would be stigmatized if they come forward and ask for help. In Europe, in particularly in the numbers and in the evidence, we see this to be very much in the gender situation. Women are much more stigmatized in this area. And we can probably make the whole list of communities and particular situations of the people who are stigmatized and that therefore have very little or no access to basic help that would save lives. This situation, and I'm going to close this situation is unacceptable, and we should call on sharp and quick action to change this. I'm quite glad seeing UNAIDS and UNODC together. I know that you work as agencies together. I'm happy that I see people from NGOs and from Drug Commission, European Commission here, and I hope this dialogue will start reflecting and rethinking the situation that can be changed very quickly, and as it was said before me, it can end the epidemic.
Thank you very much. Are you ready from your speech?
Yes, I finished my speech. Yes, I was told 8 minutes, so I was trying to fit in those 8 minutes.
Yeah, exactly. Thank you very much, Mr. Poborel, for your inspiring remarks. I would now like to turn to Mr. Matt Kavanagh, Deputy Executive Director of UNAIDS, to set the scene and provide an overview of the AIDS pandemic and the underlying social and structural inequalities. So, first of all, Matt, UNAIDS data on the AIDS pandemic and response shows that the world is off track to reaching the 2030 targets, as we have said before, including in our European Union region. So can you please explain why these targets were missed and what can be done to get the global AIDS response back on track. So you have 3 minutes.
Nothing like 3 minutes to explain the global AIDS response. Thank you, Mr. Engerer, and thank you to all of the people who have organized this really important event. We are really privileged to get to co-organize this ahead of World AIDS Day. So let me say a few things, right? Indeed, the report that we put out in July of this year shows that the world is very much off track on its fight to end AIDS. COVID-19, war in Ukraine, economic crisis for people around the world has really blown the AIDS crisis, the AIDS response off track. We now see rising new infections in Eastern Europe. We see rising new infections in the Middle East and North Africa. We see rising new infections in Latin America, and for the first time, rising new infections in Asia. And while progress is being made in Africa, in both West and Central, as well as East and Southern Africa, that progress has slowed. So we know that we're in a time where the pandemic is growing in a way that is the opposite of where we need to be. We also know that COVID-19 was hugely disruptive and continues to be hugely disruptive. For example, we did a survey that showed that 65% of harm reduction programs for people who inject drugs were interrupted during COVID-19, and we're seeing the effects of that still lingering. So we've just put out a new report our first report in July was called In Danger, and our second report out yesterday is called Dangerous Inequalities, because we asked the question, why are we currently off track? And the answer is that we haven't sufficiently addressed the inequalities that are currently driving the AIDS response. Key populations, people who inject drugs, gay men, sex workers, prisoners, now account for the majority of new infections in the world. Globally, people who inject drugs experienced 1 in 10 new HIV infections last year. And if we look around the world, what we see is that in countries with concentrated epidemics, meaning, smaller portion of the population is HIV positive, we see that actually very little progress is being made in most countries. And that's because they're, primarily focused. HIV transmission is primarily focused in key populations, and our services are not always reaching them. Now, we have remarkable progress in some places. So this should not be a council of despair, right? We can look at country after country after country and see places where, and in particular, I can name in the European Union several cities where actually HIV prevention is working, that HIV rates among key populations are falling rapidly because they've gotten access to the best biomedical technology and they've gotten access to the best social and environmental contexts. But this is not the story everywhere, not across the EU and not across the world. We now have to think about a handful of key pieces that can help us drive this forward. One, we need to think about how we address the ways in which laws and policies, political decisions that criminalize people, including people who inject drugs, actually undermine our response to HIV around the world. We've seen again and again that drives people away from services and that it undermines the way in which we respond to a pandemic when we send the police instead of when we send public health. And so our key message here is that we should send public health. We should surge that, and that addressing those laws and policies that stand in the way are key. Our second key message is that this fight needs funding. We are in the middle of a pandemic, and in a pandemic, if you're not winning, you're losing. And as we think about the HIV pandemic, we think about a moment where right now we are short by billions of dollars for the AIDS response, but that billions of dollars is a drop in the bucket for the world economy, right? One of the very interesting findings of our most recent report is that in countries around the world who have stepped up, where donor funding, like funding to the Global Fund, funding through other mechanisms, has increased, those countries have, by and large, increased their domestic funding as well. And so we have an opportunity for international solidarity, an injection of financing for HIV that would reach people who inject drugs, that would reach key populations, that would reach people around the world at the highest risk of HIV and stop the pandemic if we get that funding forward. And the third, and I'll just close with this, is that there's an urgent need for us to focus on building out the community pandemic systems that we need to fight AIDS, but that also make us more prepared for the future. right? The reality is that whether it is COVID-19 spreading among migrant populations or HIV spreading unchecked among people who inject drugs because they don't have good harm reduction services, or whether it is people experiencing tuberculosis outbreaks in informal settlements, community responses are what wins. We saw that during Mpox, monkeypox. We're seeing that in HIV. And so especially as we think about harm reduction programs run by people who inject drugs, managed by people who are from communities who are trusted, that give trusted messages, the kind of conversation that we heard just now can be reversed. We can have a situation where we lead with pandemic responses to AIDS and other pieces led by the people who are actually most affected. If we do those three things, we can actually get ourselves back on track to end the AIDS crisis.
Thanks for that clear analysis. And if I may, I would like to ask a follow-up question on criminalization, because UNAIDS monitors national punitive laws, which are highly relevant for all of us involved in lawmaking. Can you please give us and speak a bit about the negative consequences of criminalization work and the criminalization efforts undertaken as part of the 10-10-10 targets? I would also like you to share with us in a very short time, if you may, the progress for people who inject drugs, including community-led responses within the context of the UNAIDS 80-60-30 targets. And if you can do this in 3 minutes, it would be fantastic.
Excellent. Let me give it a try. So thank you for that question. Look, there's two pieces to say here. The first on law targets. So member states at the United Nations last year did a remarkable thing, setting a goal that fewer than 10% of countries around the world will have punitive laws that undermine the AIDS response. Also setting a goal that less than 10% of people living with HIV in key populations will experience stigma and discrimination. These are really important targets for consideration in the EU and around the world, because they say for the first time, we're actually going to understand law and policymaking. And for the lawyers and the policymakers on the call, you'll appreciate this. We need to understand that as a public health intervention. And so what do we know? UNAIDS has the most complete tracking of both epidemiology around the world, but also of laws and policies. We track those laws and policies and we look at their effects. And let me tell you a quick piece of what we found. In countries that take a criminalizing approach, they've made less progress at a population level on ensuring that people living with HIV know their status, that people who know their status and know that they're HIV positive are on treatment, and that those people who are on treatment are actually virally suppressed. That's the effect of criminalization, that countries that have done that, but countries that have removed criminalization or haven't put it in place the first time have seen far greater progress at the population level. That tells us that criminal law matters for everybody. It's not just those who may or may not be caught up in a web of criminalization, but actually it's that at a population level, including criminalizing the possession and use of drugs, actually undermines public health. Why would that be? Well, that would be because it really quickly drives people away from services. It also, as I said previously, kind of puts police where we need to send public health. And so as lawmakers, one of the key pieces you can support is to actually think about how do you take a less criminalizing approach. We've been working with countries around the world to say, can you repeal laws? We know that that's a possibility. We know that several countries are taking really bold steps in moving their lawmaking. Where law reform is not possible immediately, and we know that that takes time, there can also be shifts to less criminalizing approaches by police agencies, by home ministries, by a variety of different opportunities. And in so doing and partnering with public health, there's an opportunity for the justice sector to really take action. I really want to applaud Luxembourg, who has gone ahead and joined the Global Partnership on Stigma and Discrimination and focused on the justice sector. I believe that Spain is looking at taking a step to follow that as well. There's a real opportunity for Europe, along with the rest of the world, to take these issues seriously and rethink kind of how do we take approaches to people who inject drugs in particular, but to key populations overall. And then let me just really quickly mention the other piece of the targets, the questions that you asked. So you asked about the 30, 80, 60 targets, which essentially boil down to what portion of HIV services are being provided by communities themselves? And what we know is that when services are provided by community-based organizations that are accountable to their communities, they are more cost-effective and they are more impactful. Let me just tell you one example that's not from a kind of question of people who inject drugs, but of a sex worker question, or example, right? So we looked most recently in Kenya, and in Kenya overall, around the world, this is true. Key populations have lower access to services than does the general population. They have less coverage of HIV treatment if they're positive. They have less access to prevention services, less. But in 4 counties in Kenya, sex workers have higher rates or equal rates to the general population of HIV treatment. That's almost unheard of. Why did that happen? Because community-led organizations, including led by sex workers, actually won the day and put together clinics that support their peers. And so those are the kinds of approaches we know work. We know that harm reduction programs work. We know that especially when they're peer-led, they have huge impact. The 30-80-60 targets say we're going to be monitoring as UNAIDS from around the world to say how much progress are countries making and ensuring that those services are led there. And you'll see report year after year after year in the coming years about how much progress have we made on shifting toward a community-led approach. So thanks for that and much appreciated.
Thank you, Matthew. And I would like now to turn to Mr. Jean-Luc Lemahieu, who is the Director for Policy Analysis and Public Affairs of the United Nations Office on Drugs and Crime, UNODC, and an important co-sponsor to the United Nations Joint Programme on HIV/AIDS. So my question would be on the World Drug Report 2022, which indicates that people who inject drugs are 35 times more at risk of acquiring HIV in 2020. Moreover, in new HIV cases. So could you explain why people who inject drugs, including in prison settings, face greater risks and challenges in terms of HIV transmission and access to prevention, treatment, and care services? If I may, I would also like to ask you to keep to the time limit of 3 minutes.
Thank you very much, Cyrus. And it's a pleasure to speak after Matt, because Matt was already so rich in his explanation that I can refer to many of the statements he has made already previously as such. First of all, thanks as well, to our colleagues and friends of UNAIDS and co-hosting this, to the Czech Presidency of the Council of the European Union, all much appreciated on this peculiar day, that we have this common front in moving this forward. And Cyrus, thank you as well, for moderating the entire event here. Let me start where as well Matt had the initiated his part on the fact, that yes, we have made good progress, but that progress is not even, it's very uneven. And as Matt already explained, it has slowed down, or is it in cases blown out of track during the pandemic crisis, especially when it comes to key populations. So we have a lot of work on hand here. Now, you refer to the World Drug Report, and one of its main conclusions of that report is that we witness in this turbulent world of ours a surge in drug use. Now, there are multiple reasons for that: escapism combined with mental health problems, a younger and growing population, commercialization and lowering of the risk perception, many reasons, and evidently not all of this growth is translated in injecting drug use. Nonetheless, as correctly stated, those who inject drugs, including people in prison settings, face exponentially greater risks in the context of HIV/AIDS transmission. Globally, people who inject drugs, including people in prisons, face significant challenges in accessing, already talk about accessing HIV prevention care and treatment. And it was so much, enthusiastic about Matt talking about the Kenya example on the sex workers there. It is feasible if indeed you get the communities involved. Today, regretfully, we don't have that yet together at the same levels with regard to injecting drug use or the prison population. What we witness, to the contrary, far too much is stigma, discrimination, punitive legal environment, Matt laid this out, and a lack of human rights-based policing practices which have directly negative impact on those two key populations and affecting among them women the most. Now, data from both our World Drug Report and UNAIDS on the global HIV response reveal that progress in addressing the HIV pandemic among people who use drugs and people in prisons has not only slowed down and the resources have dwindled, it puts millions at risk because, of course, it's like throwing a pedal in the water, it cascades further on. And it's not necessarily because it's terrible news. We do know that in those countries that can rely on a high coverage of both opioid agonist therapy and needle syringe programs, zero or marginally few cases of HIV are reported among people who inject drugs. It does work. But more than 99% of people who inject drugs live in countries where the UN recommended levels of needles, syringes, and opioid agonist therapy coverage are simply not met. Now, what can we do? What is it what we need to do, to move that negative turnaround? There are 4 elements, and I refer to Matt here, who already eloquently laid out some of the same. First of all, it is essential to help countries in revisiting the unnecessary punitive policies and practices. As Matt stated, you don't need to see police officers where you need to see health support coming forward. Secondly, it is essential to introduce and effectively implement alternatives to conviction or punishment for drug-related offenses. And many might not know, but the International Drug Control Conventions provide for that possibility. It's not contrary to it. It fits straight within. And this needs to be done in close coordination with social support, with reintegration services, and evidently in compliance with international standards and recognized best practices. Third, it is crucial to bolster the quality, the coverage, and access to treatment of drug use disorders, rehabilitation, recovery, and social reintegration, as well as the prevention, treatment of care of HIV/AIDS, hepatitis, and other blood-borne viruses and diseases. 4, it is essential to address, and Matt already mentioned that, inequalities and engage communities to end AIDS, COVID-19, and preventing future pandemics. We know that that is indeed part of the solution. And let's think here, especially on even more vulnerable populations, the children, youth, women, people in contact with the criminal justice system, and today, those in humanitarian settings, both within and beyond the European borders. And we need to have those, very much in our mind as well when we discuss these problematics. Over to you again. Cyrus? You asked me 3 minutes. I did in 3 minutes. Cyrus, can you hear me? I guess we have a technical problem.
Yes, I can now hear you. There were some minutes of problems. So thank you for your thoughts, much appreciated. And I would like to ask you a second question, because UNODC serves as a secretariat to the 3 major international drug control treaties and as UNAIDS co-sponsor. So could you please clarify what UNODC can do to address inequality gaps for people who inject drugs in the community and in prisons, and how you facilitate or capacitate community-led responses?
Thank you very much, Cyrus. Yes, you're right. We are co-sponsor of UNAIDS since 1999, and following the Division of Labor within the UN Joint Program, we are the lead agency for addressing HIV prevention, treatment, and care among people who use drugs and people in prisons. And that's not a coincidence. This was not a choice by coincidence. It links to our other mandates, which allows building strong partnerships, not only with civil society and community-led organizations, but equally with those key entities in the sectors of health, justice, law enforcement, and prisons. Let me give you an example. When I was operational in Myanmar years back, and when Myanmar became the first country where we have opium substitution therapy rolled out at that time, it was not the Minister of Health which was in favor of that approach. It was to our Ministry of Interior, to the police, that we were able to introduce that package of services in a manner which indeed, I mean, thanks as well to the civil society, which was very helpful. I mean, I think about the Asia Harm Reduction Initiative at that moment. I think as well at the Burnett Institute in Australia. All of them were extremely helpful in moving that process forward. But it was strangely enough not held. It was our contacts with the Ministry of Interior and the police, which was enabling us to do so. So we do have indeed that kind of framework in which we can indeed, I mean, make an advocacy of others not always can do the same. We in UNODC, we strongly believe that to end AIDS by 2030 and to address the associated challenges for people who inject drugs, including people in prison settings, we must scale up evidence-based and community-led harm reduction services while addressing the existing stigma, discrimination, and punitive laws, policies, and practices. We need to do that all together. And next to the institutions managing health, prisons, and justice, involving communities is absolutely key. Matt explained that. I already referred to it as well in the first part of my presentation here. Just imagine where institutional capacity is weak. I mean, I worked for many years in Afghanistan, for example, or the trust within the government structures is very low. You cannot upscale interventions without involving the people themselves and the civil society organizations. We need to really mobilize them to move them forward. And I'm happy to say that UNODC has a grant program to support communities and civil society in scaling up access to harm reduction and HIV services in prisons and fighting stigma and discrimination. For those interested, please contact us. We can definitely work together. Now, how do we do that? How do we move forward as a UNODC? First, having strong guidelines. Secondly, having strong field presence. Third, rolling out technical assistance, both awareness and sensitization combined with capacity building. Fourth, focus. We cannot be everywhere. We have limited funding, it's clear. We focus on 24 high priority countries for people who use drugs and for 30 high priority countries for people in prisons. By the way, the same countries prioritized by the EU is the same level of countries, such as we know Sweden, France, and Germany, who have provided financial support for our interventions. And under the EU Drug Strategy and Action Plan as well, we see a lot of room for further cooperation on drug demand reduction, prevention, treatment, care services, addressing drug-related harm, and international cooperation. And let me add the fifth one to the four previous one, link it with an eye to other comorbidities such as viral hepatitis, TB, and STIs. I mean, have that comprehensive approach which affords the entire health package. So I leave it up to them. Thank you very much, Cyrus.
So thank you, Jean-Luc. Unfortunately, I'm having some connection problems. Hopefully, it is. Thank you. Hopefully, it's not another Russian cyber on the system because everything is stopping all the time. But we will continue. Since we have some small time, I think that Jandrik Voboril would like to come in for a second. So I'll, if possible, 1 minute, Jandrik, so that then we'll go to the panel.
I appreciate what Jean-Luc said about the possibility of being within the conventions, but the drug conventions, and allowing harm reduction policies, but in a way lifting stigma from drug users, and at the same time criminalizing possession and not allowing regulated market is actually a contradiction, isn't it? It's we have to make a decision whether we want one or the other. I think the two together is a contradiction. As much as we understand that we are concerned with all the risks attached to drug use, but at the same time, it's not possible. It's not possible lifting stigma when we have punitive laws about drug possession. It's just not possible. And the conventions strictly say that certain type of drugs on the list are not allowed to be regulated on the market. That's the year-standing explanation of INCB and their report. So maybe we should make an amendment to the conventions. I know it's almost impossible, but
I second that, and I agree with you myself. And I'm working with actually a Czech member of the European Parliament, Mikuláš Pecka, on something similar here in the European Parliament. But we now need to move on, because we're running slightly late, to our panel discussion, in which we will have a discussion on effective responses both at community and policy level. We have with us Ms. Judy Chang, Executive Director of Input, the international network of people who use drugs, Mr. Philip Rupp, who from the G Santé, Dr. Julia Del Amo from the Ministry of Health of Spain, and Mr. Joris Jurens from the Ministry of Foreign Affairs of the Netherlands. So thank you very much for being with us today. And I'll start with Judy first. So Judy, from your perspective, what are the main challenges faced by people who inject drugs in terms of HIV prevention and treatment in our European Union region? And what is the role of community-led organizations? I will not repeat this every time, so I'll just do it now. So even for the panel discussions, we have 3 minutes for answers so that we keep on time. Thank you.
Thank you. I'll try and speak quickly. So, of course, as the other presenters already discussed, as people who use drugs, we simply don't have the same level of access to health services that we need as the general population does to the health services that they need. Only 1% of our community actually live in countries where there's high coverage of harm reduction interventions. Of course, the underlying reasons for this, range from inappropriate service design and service and delivery modalities to harmful political decision-making that drive and entrench social inequities. So across the EU region, progress on access to HIV prevention and treatment remains patchy and uneven. We really do need a standardized approach, and we know we have the body of evidence to reduce HIV incidence and prevalence amongst people who use and inject drugs. But despite this, we are still seeing sharp increases in HIV amongst people who inject drugs. For example, in Greece, along with continued high HIV incidence rates in Russia and Ukraine, and globally, as Matt Kavanagh already shared before. This is totally unreasonable and unconscionable, given that we know we have the tools at our disposal. And the reason is that we're simply not getting the commodities needed that we know work, needles and syringes, opiate agonist treatment, and naloxone into the hands of those who need it, either due to restrictive laws and policies, underinvestment and deprioritization of people who use drugs, or because services simply aren't designed to be fit for purpose. On one hand, in the EU region, we see amazing initiatives that really enable health equity, like, for example, mobile methadone clinics in Portugal to drug consumption rooms in Spain and Switzerland and other countries, but these models aren't being scaled up. And on the other hand, we're seeing nationwide bans on opiate agonist treatment, and we're also seeing severe funding cuts to harm reduction services in EU member states. There's a long history of harm reduction in EU member states, but only the Netherlands is on track to meet the 2025 prevention target. And we are seeing this backtracking progress. And I think some of this is attributable to emission creep. We are seeing diversion of funds from evidence and rights-based interventions, such as harm reduction, towards abstinence-based approaches. And we really need to ensure that science and evidence trumps moral imperatives. But of course, it's difficult to imagine a scenario where we can fully shift towards evidence and rights-based services for people who use and inject drugs as long as we remain criminalized. Again, there are stark differences between EU member states. For example, Germany, Czech Republic, and Portugal have decriminalized personal use and possession. And Input wants to emphasize also that we see this as a first step towards legal regulation. But most countries still do criminalize and punish us so that we fear arrest simply for engaging in services. Really wanted to emphasize that we're not being left behind. It's more that we're being pushed behind by laws and policies. So, of course, one of the primary effects of criminalization is stigma and discrimination. They feed into each other, and this really colors, our lives as people who use drugs. We're told that we should not exist, treated as morally deficient and incapable of knowing our own minds. And this, of course, shapes the way that we engage with health services. There are policies and regulations that explicitly discriminate against us to the point of denying treatment. Programs that serve us are not funded or are underfunded. And we tend to avoid health services because at the end of the day, who wants to engage with a system that shames and degrades us? And just finally, of course, the role of community-led organizations, I agree with all the other speakers, they're critical, but how they work is that, we're able to better navigate the barriers posed by criminalization, stigma, and discrimination. We can better reach people who have little trust in mainstream health services, and we're able to better design and deliver services that are core and aligned with people's lives and experiences. Also wanted to point out, the mere existence, I think, of community-led organizations, especially when we're criminalized, is a challenge to the status quo in and of itself. And it proves that, structural oppression doesn't stop people from, demanding our rights. Yet we are vastly underfunded, as shared by Matt before. Key populations make up 70% of new HIV cases, showing that we're evidently not putting the right amount of importance and resources into the right channels, and we really need that course correct.
Thank you, Julie, for your thoughts. And I would like now to turn to Mr. Philip Roux, representing the G Santé. So, as you heard from Judy, she has articulated the main challenges faced by people who inject drugs. Philip, can you outline for us how the Commission can address these challenges?
Thank you very much for giving me the opportunity to share with you today. It's very clear that the Commission services are well aware that people who inject drugs are disproportionately affected by HIV and hepatitis. We're also conscious of about the difficulties they face on their healthcare. And it's a privilege, of course, for me to hear it from you directly and from the community organizations who are working on the ground and representing the voice of those people who use drugs who actually are not very often heard directly. What I want to recall first, because it's very important to address the Commission, and I understand that, but it's very important for me to recall, as always, that health is and remain in great part the direct responsibility of member states, and that the EU has the modest role to support them. So that it's really to be kept in mind when you hear my contribution to the discussion. So having this in mind, I think we acknowledge that it is vital that people who inject drugs have easy access to quality testing, to treatment and care in all member states in the EU. Firstly, we must find effective ways to connect to this key population, to talk about their health problem and find solutions. The community services ensure a crucial link to health and well-being of these individuals. And as the Commission is already investing over 7.5 million euros under the EU for Health program in at least 5 community-based projects that will work to help people who are disproportionately affected by HIV/AIDS, viral hepatitis, and tuberculosis, and for them to have easier access to quality care service. As well, 2 operating grants supporting community organizations working on responses to these diseases. And for example, I can mention the Boost project, which with a budget of a bit more than 1.3 million euro, 1.4, nearly 1.4 million euro, which will start on the 1st of January 2023. And that will work for 3 years on improving access and quality community-based services for people who use drugs in the EU and neighboring countries. As you know, when you use money, you do policy. The way you use your money is making policies. That's important also to mention. Secondly, what I think is important to mention here in my 3 minutes is that there is the health policy thematic networks for the year 22 that includes a network on HIV, tuberculosis, and viral hepatitis, as well as sexually transmitted infections, as well as other networks on anti-discrimination and health equities. I think these networks, which are led by the stakeholders, by health stakeholders, and they are hosted by the Commission EU Health Policy Platform. I think this platform is worth mentioning. I mean, before COVID, I mean, it was hardly considered as serious, any activity online. Now, most of our exchanges, even today, we are online. So the policy platform, which was created before the COVID crisis, is now more and more bearing fruits. And I know that the networks there will generate a joint statement containing actions to be put forward for and by the stakeholders on this topic. Because I think here also my second key message here on that point is, yes, indeed, the Commission has to do, but we cannot do alone. So it's a question of everybody has to do his share. So that's very important. And I think in this joint statement, I mean, that give directions not only to the Commission, but also to the stakeholders engaged. So anyone interested, I mean, including the audience of today, may actively participate in the thematic networks cycle. And it's an opportunity to have you say, and I think that's very important to mention. So live webinars are coming soon on these subjects, and you just need to keep an eye on the health policy platform web page. Thirdly, we are conscious of the complexity of a diverse level of standard of prevention, treatment, care, and information services for people who use drugs in healthcare systems in the member states. There are many differences. And to this end, the Commission supports member states' efforts in health promotion and disease prevention through upscaling and transferring promising approaches and best practice across the EU. That's a standard approach for all issues we have in health, including those that we are talking about today. And since 2018, a wide range of best practices have been collected already through the EU Best Practice Portal in the field of non-communicable diseases. The EU member states in the steering group on health promotion, disease prevention, and management of communicable diseases have selected best practices which add value to their national programs and policies. And the EU health program supports implementation between the member states. So this is a mechanism which is very important to understand and have in mind. So it is very clear that the member states, we have organized so that member states, they are in the lead in choosing the directions, the areas. So they are fed with good practices, and then they decide which directions and which area they want to focus on. And then we serve these focuses. As I said, the Commission is really here to serve. So here it's important that you convince your national authorities, then it can trigger easier the EU health program funding. So I think we have already a number of activities I can report on. For example, we in the work program 2022, member states are preparing now a proposal for joint action. So member state joint action on diabetes and cardiovascular diseases, as well as on other determinants. And that it is important to mention the on other health determinants. So this kind, as I said, this kind of business model of collecting and selecting best practice supports national and EU level policy making. And that's, for me, an important element to mention. So the scope of the activities will be widened to cover persistent public health concern, because we were before only on non-communicable diseases. Now, we want to include also hepatitis, HIV/AIDS, and as well as challenges like vaccination strategies and antimicrobial resistance. And it should be stressed that the actions of the new group that we will create to replace the one we are working so far will not overlap with the Health Security Committee's action, which provides synergy in collecting promising and best practices for policy making. So it's very clear that the SGPP will be replaced by a group that will cover more angles than before, and will cooperate with other important actors in the EU. So the work plan for this new expert group that we are building is planned to be prepared early 23, and it will be followed by a commission adoption in the course of the year. And the member states will be discussing, and that it is what you need to keep in mind. We'll discuss the different topics, including HIV/AIDS, TB, and hepatitis, or vaccination policies could be put on the agenda of the group to support national efforts in reaching and as you know, this falls within the SDG 3.3. So we are aiming at achieving this sustainable development goal here. So the Commission really support member states' effort in the area of health promotion and disease prevention through upscaling and transferring promising approaches and best practice across the EU. Lastly, and perhaps the less common to hear in such a fora for you, is the European Beatings Cancer Plan, which is a key priority from our president, as you may know, in the area of public health, and is a cornerstone of the European Health Union. It explicitly recognizes viral hepatitis as a preventable cancer risk factor and includes actions to combat it in activities on cancer prevention. So here, for instance, there will be a joint action on cancer and disease prevention, which was launched on September this year. And this action will help tackling hepatitis detection and treatment alongside the more established health determinant, harmful alcohol consumption, tobacco, nutrition, drugs, etc. So here there is another hook and of activity that the Commission made possible to work on. And in the future, a council recommendation of vaccine preventable cancer could help. Sorry?
If I may ask you to conclude, because we're running.
Yes, I'm definitely. I was just in my conclusion line. So indeed, I just wanted to add a last point. I know it's a lot of information, but I thought it was important to share with you, so that we are working on a council recommendation on vaccine preventable cancer that could help member states indeed addressing cancer risk linked to hepatitis B virus by upscaling the uptake of vaccination in both general population and at-risk population we are talking here today. Sorry, it was a bit long. I'll be shorter with if I have to.
Thank you very much, Philip. And Ms. Julia Delamo, I will now come to you. You are the director of the Division of the Control of HIV, STIs, viral hepatitis, and TB in the Spanish Ministry of Health. So the question is with regards to Spain and the releasing of a new HIV action plan. Can you tell us how the specific challenges faced by drug users have now been integrated in 3 minutes, please? Thank you.
Thank you for inviting the Ministry of Health to this important dialogue. As you were saying, we released our prevention plan for HIV and STIs last year, 2021, going up to 2030. And this plan has 4 strategic objectives on primary, secondary, tertiary prevention, plus a 4th one on quality of life. And there are overarching principles for universal access to health, an inequality lens, and complementarity with other plans. And in this complementarity, I want to raise the complementarity with the National Plan on Drugs, which is a very strong body in Spain who's been working on it for the last 30 years. And of course, we are addressing the specific needs of people who inject drugs, focusing on primary prevention by stressing the importance to maintain and revitalize harm reduction programs, needle exchange programs, methadone substitution, and drug-free programs, as well as pre-exposure prophylaxis, post-exposure prophylaxis in condom prevention. So the specific needs of people who inject drugs are highlighted. People who inject drugs are identified as key populations, and there is a very strong focus on primary prevention. But we are aware that in secondary prevention, this is also very important, because testing for people who inject drugs needs to be linked to starting ART, and this is challenging for people who inject drugs. So the specific programs to outreach and to facilitate linkage to care for people who inject drugs and initiate ART is also contemplated. It's been mentioned here the big importance of comorbidities in people who inject drugs. Our plan in the new division integrates viral hepatitis and tuberculosis. These are key comorbidities in people who inject drugs, together with other STIs and mental health. So the plan is also addressing the specific needs on this population. And we endorsed, really, because the Social Pact Against Stigma and Discrimination was a community initiative from 2011 that was adopted and promoted by the Ministry of Health. And this important pact against discrimination and stigma has a number of ambitious objectives, many to do to remove these laws and policies that discriminate people with and at risk of HIV. And there are a number of global actions, but also specific actions for people who inject drugs. Just to finish, we also work in very close collaboration with public health in the prison system. As you know, Spain was one of among the earliest countries who introduced needle exchange programs in the prison setting, and this continues to be working, and they're part of our governance commission, together with NGOs and civil society associations integrated by people who inject drugs. Over to you.
Thank you. And we now move to the Netherlands from Spain. I'm not sure whether you can hear me, but we will now move to the Netherlands with Mr. Joris Jurens. You are the head of Global Health and SRHR Division in the Ministry of Foreign Affairs of the Netherlands. So the question is, can you please share your insights on the Dutch approach to drug users in the context of your national HIV response?
Thank you so much. In the Netherlands, we have a balanced approach at the core of our policy. We believe that health and rights. I don't know
whether I was heard, but I'd like to thank you, Julia, for your interesting comments. And I would like to now move to the Netherlands, where Mr. Joris Jurens is the head of Global Health and SRHR Division in the Ministry of Foreign Affairs. So Joris, can you please share your insights on the Dutch approach to drug users in the context of your national HIV response?
Thank you so much. And of course, we have a balanced approach at the core of our policies. We believe that health and rights for people who use their drugs are key in effective drug control. People who use drugs need care and support. Dignity for who they are, their story, their choices in life are crucial in preventing more harm for themselves, their families, but also for society. we have a target group approach. Prevention is key when it considers people from initiating the use of drugs. Therefore, we priorities prevention towards young people and youth in the Netherlands, prevention to use drugs. But for people who use drugs, we emphasize the prevention of harm to their health and to their addiction. And for people who struggle with an addiction, we ensure that care for their addiction is available. As mentioned, harm reduction is one of the pillars of our drugs policy. Harm reduction programs are carried out at municipal level by municipalities in close collaboration with addiction care, governmental structures. And we have needle and syringe programs, supervised consumption rooms, methadone and medicine, heroin services. This is successful, and as mentioned by Judy, we are on track here. This has taken drug use infections. This has taken drug use off the streets and off public places like train stations. This also has been leading to almost zero new drug infections among young people who use drugs. This is really a big win in our national drugs policies. I have to admit that we also face challenges. We have to face challenges, for example, with elderly people, older people who use drugs, survivors of the heroin addiction in the 1980s. And we try to come up with innovative solutions such as elderly homes, which provide that they, with tolerance for drug use, for people with lifelong addictions. This has been, for example, set up in my town, The Hague, in an elderly house called Woodstock, which at first got some resistance of the community, but now is rather successful and a successful example to include these people. Another worrisome tendency is the rise of chemsex, especially amongst men who have sex with men. We work together with the NGO Mainline on creating awareness here. A special focus is also on homeless migrants, European problem, where you see that homeless migrants are excluded from care and are extra vulnerable for drug use, but also for infectious diseases. It is important to keep focus as well on these vulnerable groups. In conclusion, acceptance for drug use is essential. To receive mental care, of social support, it should not be mandatory to stop the use of drugs. Experience has been learning that this pushes people away from care. Stigmatization is not effective. A balanced approach. Of course, we are tough on drug crimes and drug trafficking, but drug use and drug possession should be treated more on the health side of things. Thank you so much.
Thank you, Joris. And undoubtedly, the illegal Russian invasion of Ukraine has had an impact on all of us. But imagine the impact it is having on those on the ground in Ukraine. And I would like now to invite Anton Bantsenko, who has a comment on community-led responses on HIV and harm reduction in Ukraine. Anton, the floor is yours, and thank you very much for being with us today. So, can you hear us, Anton? Can you hear me? So you just need to unmute.
Okay, yeah, finally, because it was prohibited by the host. Hello, I'm Anton Basenko. I'm a person living with HIV and a person who used drugs 20 years so far, and I'm Ukrainian. I'm really honored to be invited here and proud to give a comment and to speak on behalf of European community of people living with HIV, as well as Ukrainian community of people who use drugs. You know how many years communities are talking about community-led responses in HIV to provide real, not just declared, rights-based and people-centered approach in health services. And this is very right time to understand where we are and what else has to be done. Given that my speech is based on Ukrainian experience, when I say it's the right time, I mean actually not only the World AIDS Day, but also the war in Ukraine, of course, and geopolitical processes which taking place right now, right in the center of Europe, after 24th of February. Well, at the time before the war started, and as well as before COVID pandemic, Ukraine, though it was the second most affected country with HIV in the Eastern European Central Asian region, but we had the largest harm reduction and opioid agonist therapy program in the region. And we took HIV epidemic under control with quite a good perspectives and results. So what we've learned so far, that such an emergency context turns to a real window of opportunities, and exactly community-led responses bring this added value and, you know, this kind of a moving force to positive changes. Community producing the ideas, community can advocate for increasing take-home dosages, community shows what are and where are the needs. We can deliver, help with the delivery of antiretroviral or opioid agonist therapy treatment. You know, it's a medical assisted therapy for stimulant users. It's a vending machines, it's a transportation, evacuation, shelters, gender sensitive services, online approaches, basic needs, mental health services. It's a really long list of things which appeared or has been catalyzed during the COVID pandemic or the war. And things were community-led or community-led or contributed to that successes. And despite of COVID and war, first, programs in Ukraine were not interrupted. And second, the coverage of people who use or people who inject drugs even increased. And programs are innovative. Let's say honestly, when you live many years in the war mode, I mean war on drugs, and one day another war comes to your life, it's sad, it's terrible, it's unbelievable, but you are kind of prepared. And you just turning on the emergency mode and moving forward, saving lives of your peers. But talking about inequalities, let's keep in mind that it's not only issues of refuses in accommodation and shelter, what we faced, or quality of harm reduction supplies or opioid agonist therapy medications, or still not approved new drug strategy. It's also issue of health-related quality of life of those people who inject drugs and living with HIV. I mean, things like aging, multimorbidities, mental health, etc. So let's go further than just 95, 95, 95 paradigm. And finally, I want to say thanks to countries who are present here, Czech Republic, Spain, Malta, Belgium, Netherlands, all European Union countries. We use your experience. You help us to be capacitated and to be empowered, to be structured, drug users network to be structured. Of course, your enormous support and help to Ukrainian refugees in the EU as well as internally displaced people in Ukraine. And finally, your help to overcome financial challenges. And I mean, not just direct funding, but as well as your investments into the Global Fund, which actually turned out to be a first donor who came to help immediately Ukraine in terms of war through reprogramming of funds. And also organizations like Aidsfonds through and initiatives like emergency funds, like Drug Users Network now has a vehicle which helped to evacuate hundreds of people from the front line, including recently evacuated Igor Kuzmenko, our activist, who spent 8 months in Kherson under Russian occupation. Of course, thanks to UNAIDS and UNODC for this political pressure, we feel your support. You know, Ukrainians are a strong nation, and people who use drugs, they also defending our country with a weapon in their hands in the territorial defense unit or even military forces. But this is just to say, and just to remind to all of us, this is not just a war of weapons. It's really war between old, dark, and repressive world where Russia did everything to kill, harm reduction, opioid agonist therapy, gender and human rights program in the entire region, and war with a new progressive European world where people who inject drugs are decriminalized. No, we see no stigma discrimination. Human rights and communities are respected, and communities-led responses is a really standard approach. Please keep supporting Ukraine. Please keep supporting communities. Equalize, and Slava Ukraini. Thanks.
Thank you, Anton, for reminding us of the stark realities faced by the people of Ukraine, including those who use drugs. And we promise that as a European Union, as a European Parliament as well, we will continue supporting Ukraine in all its needs, not only during the current Russian invasion of Ukraine, but we'll do so even after Ukraine's victory in this invasion against Russia. So now we'll go back to the panel that we have with us. So Judy, once again, can you please share your reflections on the approaches outlined by previous panelists and articulate the kind of additional support that community-led organizations need?
Thank you. And I just want to thank Anton for your intervention, everything you do, of course, for the community in Ukraine and regionally and worldwide. So yes, it was great to hear the other panelists and to hear about lots of important initiatives coming from the European Commission and Spain and the Netherlands, including increased investments and service packages for people who use and inject drugs. You know, obviously there's a lot of focus on integration as well, and also looking at viral hepatitis and addressing viral hepatitis, TB and STIs, and important to focus, of course, on youth and elderly. So to look at people who use drugs, use and inject drugs across the whole life cycle. I just want to check I can be heard, Cyrus. Yeah, okay. Great. And I think, yeah, it was also positive. You know, there seems to be a lot more focus on addressing stigma and discrimination also. Yes, but I also think, yeah, it'd be great to hear more, or to look at, you know, how much funding is being and how much support is being directed towards community-led organizations, you know, in line with the 80-60-30 targets that Matthew Kavanagh mentioned before. So 80% of prevention services to be delivered by communities, 30% of treatment, and of course 60% of funding for advocacy as well. I think also, yeah, also important to look at the UNAIDS definitions of community-led organizations. You know, these aren't always the same as broader civil society or community-based organizations as well. So, of course, important to look at applying both these definitions and also the targets at the national level, and of course, making sure that they're funded. You know, the value and impact of peer-led responses has been documented, but I think not well, you know, enough. Input has published some case studies and some articles in peer-reviewed journals. And as Philippe from the European Commission mentioned before about the importance of having compendiums of best practices, it'd be great if these would also, you know, feature community-led responses also in line with the 80-60-30 targets. I also think, yeah, in asking for what kinds of additional support is necessary. I think, you know, it's important to look at having dedicated funding streams for key population-led, including drug user-led organizations, rather than, you know, having us compete with larger civil society organizations. You know, we do start from an inequitable playing field, you know, because of laws and policies and restrictions. And, some important, I think, examples of this are the Love Alliance, so the Dutch-funded MOFA initiatives that supports key population-led advocacy for human rights and health, and the Robert Carr Fund, a pooled funding mechanism that prioritizes inadequately served population-led networks. I think secondly, in looking at supporting community empowerment and movement building, it's important to recognize that it's not always a linear process. It takes time, like all things, it takes time to grow and develop, as all things of value, and it doesn't always fit into neat quantitative indicators. Because we work on behalf of criminalized populations, in many contexts, for governments that are also funding networks or initiatives in other countries beyond the EU, we're not always able to register or open bank accounts. And I think it's important donors that have a commitment to fund us look at entering into dialogues about how to balance that accountability with the realities of the context in which we operate. And governments should look at either lifting restrictions themselves or pressuring on lifting restrictions on registration, in line with the human right, of course, of everyone to freely assemble and associate. Of course, another way of supporting as for decision makers, access to decision.
Conclude your remarks.
Yes, just to make sure that decision makers, always including people who use drugs, sit at the table. And, in short, in summary, drug user-led and community-led organizations both need financial support for the range of services initiatives that we deliver, from services, advocacy, research and evaluation, and of course, the political support to elevate our role in the HIV response. Thanks.
Thank you, Judy. And I will now go to Joris, Philip, and Julia again. I will give you a bit of a challenge, because I will ask you to speak as we do here in the European Parliament. So 1 minute each, if possible, because we're running quite late on time, and I would really like to give some time also to the audience for their question, and we're running even late for that. But so quickly, we'll start with Joris, 1 minute, about the Netherlands, since you're doing very well on HIV prevention and harm reduction, but this will obviously need continuous focus and investment. How have you addressed the health rights and social needs of people who inject drugs within your new global health strategy?
Thank you, Cyril. We indeed announced a Dutch global health strategy last month, focusing on what we are good at, and that counts a lot to SRHR, including HIV/AIDS. We like to call ourselves a donor with courage, investing in those issues where not all other donors are investing in, like comprehensive sexuality education, but also reaching marginalized groups. Our strategy has a strong focus on preventing and treating infectious diseases, including HIV and TB, and we support the full range of SRHR activities. In this frame, we have been augmenting our support not only to the Global Fund, but also to UNAIDS and the WHO. We cannot do this alone. We work together with civil society in this respect, prioritizing community-led organizations. Judy mentioned the Love Alliance, which we support also through the Robert Carr Fund, which empowers regional networks of key pops. In summary, we need strong commitment from civil society, from governments, from local organizations on the ground, who know the realities of people who use the drugs. Lastly, important to involve also young people who use drugs and women who use drugs, which are vulnerable and many times excluded from care and support.
Thank you. Undoubtedly, the intersectionality of drug users should also be taken into account. So, Philip, we often hear that within the European Union, there is more concern about drug control rather than about the health, the well-being, and the rights of those people who use drugs. So building on the experiences of the Netherlands and Spain, can the future EU Global Health Strategy address these and also foster greater harmonization across European Union member states, particularly when focusing on HIV prevention in drug users? 1 minute, if possible, please.
Okay, so my clock is ticking. First of all, what is important for me is to underline that the EU's action in the field of drug policy are framed first by the EU drug strategy itself and the related action plan for 2021-2025. Therefore, there is a balanced approach. So there is no more on the one hand and less in the other hand. And indeed, the strategy and the action plan seek to address and counter drugs comprehensively with a balanced, and I insist on that word, focus between enhancing security and reducing drug demand. And for example, by means of prevention, treatment, care services, and action aimed at addressing drugs-related harms. I think here action to maintain and enhance harm reduction measures and to promote rapid tests and self-testing or maintain or scale up outreach programs to reach the most vulnerable people are part of the activities to which the member states, the Council of the EU, the European Commission, and the European Monitoring Center for Drug and Drug Addiction are committed to. And I think the EU's commitment to a better health for all will be further demonstrated in the upcoming EU Global Health Strategy, where these dimensions will be considered. 1 minute, 26 seconds. Over.
Thank you. It's always very difficult. I always have the difficulty in the plenary and in the committees myself. Last question to Julia. So Spain intends to include HIV-related stigma and discrimination in the agenda of the Spanish presidency of the Council of the European Union, which I personally obviously applaud and really, really welcome. Can you please clarify how you intend to consider the specific needs of people who inject drugs in terms of stigma and discrimination to ensure tailor-made recommendation actions? 1 minute.
Thank you for sharing our enthusiasm. We're really excited about our working plans for 2023. We've started working all year, and I see Jantine smiling because together with UNAIDS, ECDC, WHO Europe, and a Spanish interdisciplinary association, SEICIDA, that is led by people with HIV, including people who inject drugs. We've already met 3 times. We're working on a document. Jantine, the draft is going to be shared with the group, and this core group will very soon expand to other groups and expand to networks of people who inject drugs to incorporate their input and tailor interventions. We are very aware of the intersecting stigmas that people who inject drugs experience, and we're very aware that the sum of individual stigma adds up more than the individual sum. We're very conscious about that. So the plan is ongoing. We've got a high-level meeting planned possibly by July 2023 in Madrid. And we expect in the first term 2023 to be reaching out to many of the people in this call. So bear with us, help us, and share our enthusiasm. Over to you.
Thank you very much, Julia, and I look forward to the Spanish presidency. I'm sure that it will be a great presidency for issues that are usually seen as a taboo, as has the Czech presidency been in the past few months. So we will now move to the question and answer session. We do not have much time, and I thank all the online participants who have been with us today for your interest. And there are already many questions in this chat, and I would like to encourage you to keep on asking questions. We may not be able to answer all of them today. However, all will be responded after today's session. So I would like to ask the panelists to once again be brief. I will ask a few questions to you, which have been identified from the chat and from questions coming in. So the first question is from Adria Coates Fernandez from IDPC, who's asking, what steps is the European Commission taking in order to promote increased funding for harm reduction and reform of stigmatizing and discriminatory legislation against people who use drugs in the European Union. So maybe, Philip, you can answer this in 1 minute, please.
Sorry, I unmute. Yes, indeed. 1 minute. So clearly, I think what is important to mention here is that a number of financing tools are at the service of these aspects. First of all, and I've mentioned it in my previous intervention, the EU for Health program, but we also have Horizon Europe, cohesion policy funds, the Digital Europe program, and the Right and Values program. So a number of tools are made available. And of course, the applications always should be considered in view of the legal scope and of the individual program, so that it is the only constraints I would mention. But there are a number of programs that are available and perhaps underused by, I would say, the actors in the field.
Thank you, Philip. And the second question is from Joseph Holloway. It's about correlation. How do you plan on reaching the communities which are the hardest to reach and are reluctant or fearful of interacting with health services? And if I may, I would ask Judy to please answer this question in 1 minute.
Sure. I would try. Yeah, just to preface with INPUD, don't deliver services, but obviously we partner with a lot of grassroots organizations that do deliver services. So I think, yeah, for people that are fearful of interacting with mainstream health services, with peer-led services, obviously then they're interacting with people with similar life trajectories, right? So there's that trust and that empathy. I think, yeah, as Anton already mentioned before, during COVID, a lot of the peer workers were putting themselves, at risk, when we all didn't know what COVID necessarily meant. And I think, end users, clients, could see that workers were putting themselves at risk. I think also with peer-led responses, there's that space for innovation. They respond to what the client needs rather than, this top-down way of designing services. So for example, it's not just delivery of commodities, but if someone needs, accompaniment to get their ID, or, their identity documents to be able to register to receive social services, that's what many peer-led services do. So I think that's, it's the piece is really around trust and responsiveness.
Thank you, Julie. I have some technical issues again. I hope that you're hearing me. So the third question is from Oriol Esculias from the Asociación Proyecto Hombre from Spain. And to what extent do governments and civil society organizations, can you hear me? Okay, so I had some technical issues once again. So I'll go to the third question, which is from Oriol Esculias, Asociación Proyecto Hombre. And the question I would ask input from Judy, Joris, and Julia. To what extent do governments and civil society organizations coordinate to improve HIV and drug policy? So I'll start by you, Julia.
Thank you, Cyrus. I wanted to comment on the previous question that all of this is essential, but we need universal access to healthcare as the mandate for every country. Without that, things are very complicated. I don't know if I was heard. I was just reminding everybody of the importance of lobbying for universal access to healthcare. And regarding the question by Oriol Esculias, well, I can share what we are doing in the Division for HIV Control in the Ministry of Health. We've got a governance body that meets regularly where people with HIV from different key populations meet regularly and provide their views, their feedback, their proposals to the Ministry of Health, together in coordination with the National Plan on Drugs. I am sure there is room for improvement. It's very frustrating when you examine yourself and understand there is much more you can do, but we've got mechanisms in place in Spain. Thank you. Over to you.
Thank you. So we'll move to Yuri. Yuri.
Thank you very much. As I mentioned, Cyril, we work very closely together with civil society, and it concerns both our national health policies, where we have institutionalized cooperation between governmental and community-led activities for harm reduction. Think, for example, on the role of the Trimbos Institute, a research institute for mental health and addiction, which is part of the formal harm reduction network. But also in development cooperation, we work very closely with civil society to reach community groups, for example, with Aidsfonds through the Love Alliance and with the Robert Carr Fund.
Thank you. And finally, Judy.
Yes, I mean, I think the answer, really depends across contexts and different countries. I mean, from input, we work globally. We interface, closely with UNODC, HIV/AIDS section, of course, worked with UNAIDS, WHO, and worked on developing normative guidance and target setting. So those, those were really important areas of involvement. But yes, at the country level, we definitely see different things. Sometimes communities are shut out, other times, they are involved. I would also emphasize, but they are involved. It's important that, they're not only involved during the development side for single meetings, but, through also being able to monitor and evaluate, the impact of policies and programs as well, because it's always important to understand, the lived impacts. Also, I think, a lot of the times communities may be engaging with one department, the Ministry of Health, but of course, for, reasons of stigma, discrimination and criminalization, are not engaging with Ministry of Interior or Ministry of Justice that, have more kind of say over, obviously, drug policy. So I would just say, yes, it definitely differs, and we need to see, more consistency in that approach.
Thank you very much. And I think we should conclude the question and answer session. We're only 4 minutes late, but 3 questions were very interesting, sufficient, but do not worry. All of those who have asked more questions in our chat, we will be replying to all of them after this conference is ended. And I would like to conclude this very interesting and informative session by asking the contributors to share one key takeaway and one key policy recommendation to the EU on what the EU and the EU Global Health Strategy should consider in terms of equitable access to HIV and health services for people who use drugs. So, Jean-Luc, can I start?
Thank you very much. And indeed, I mean, Cyrus, this was a very interesting discussion. I really enjoyed and benefited a lot from all that has been stated here. So thank you very much, for all the panelists for your very welcome contributions. Let me, if you take something to have with us here after this meeting, I would first of all give a little bit of a warning signal that especially in turbulent geopolitical times, we simply cannot wait until the big legal transformations are to befall on us. We need to be seen realistic, acting, and creative. And countries such as Portugal have proven in practice that creative and excellent work can be done within the framework of the existing conventions. And 2 elements which I would like to take with me here, and I do refer, and I really benefit from the richness of the discussions I have heard here, is first of all, prevention. I think indeed that the Netherlands was very strong on the fact, that it is fundamental to promote initiatives and campaigns that aim at raising awareness about both the harms and the challenges posed by illicit drugs to the society as a whole, and especially the young. But having said that, and that was very correct, for those who use drugs, we need to prevent and reduce the harm. That's why we're sitting here together today. and having government, academics, civil society to work closely with community-based approaches and peer-led responses, including organizations and networks of communities of people who use drugs, is indeed to avoid the top-down approaches. And I think indeed Judy Chang mentioned the same. So thanks for all of that, very inspirational. And I leave you with those messages here. Thank you.
Thank you, Jean-Luc. And Matt, your one key takeaway and one key policy recommendation.
What a fantastic conversation. Thank you all for such robust contributions. I think, key takeaway here is I think I'll just echo what was just said. We have to work on the long term and the short term together. That means ensuring that we are working toward legal environments that work for people who inject drugs, work for key populations around the world, because without those, we're not going to get to the end of AIDS. But we cannot wait for law reform, and there's lots to be done beforehand. And so I think the one key recommendation on our part is about funding. We see right now a really heavy gap, and I've just put this into the chat. So for folks who are interested, there's a screenshot of part of our report that just came out for World AIDS Day. And what it shows is that we know to get to the end of AIDS, we need to fund the social enablers. That includes the work on law reform, but it also includes all of the work in community-led responses. It includes those ways in which prevention services get provided by communities themselves. And it includes the transformational work that we've heard about today. That work is deeply underfunded. I put in the place a graph that shows that, for example, in Eastern Europe and Central Asia, the recommendation is that 23% of prevention, or 21% of prevention funding needs to go into that. But in fact, currently it's 3% because of a gap of funding. If we look at West and Central Africa, for example, 16% should be going in, but 2% is. And so there's a real opportunity in the global health strategy of the European Union to say, we're going to focus in on these areas that are currently underfunded, these social enablers that are transformational, that matter for the end of AIDS, that matter also for pandemic preparedness. The other key takeaway I would take away is that all of what you've heard right now, these are the communities that are mobilized to stop every pandemic, right? And so these are the folks who mobilized in COVID-19. These are the folks who mobilized during monkeypox, et cetera. And so we need to actually think about this as core to our prevention efforts of all pandemics. And so in that sense, funding these social enablers is really worthwhile and would be great to see that strongly in the strategy going forward. Thanks so much.
Thank you. Judy, a key takeaway and a key recommendation?
Well, it's really about centering not only the meaningful involvement, but also the leadership of people who use drugs, and that it's a matter of equity and epidemiology. I think, the vicious cycle that we find ourselves in, it's really going to continue unless we, I'm starting my video, unless we, commit to moving away from business as usual. And I do think these 10-10-10, 80-60-30 targets, are a flag to moving away from business as usual, or a signpost, a milestone. And if we do, succeed in pushing towards these targets, I think there's many broader lessons for equity and global health overall. I think, as we know, if health systems work for the last mile, that is key populations and people who use drugs, then it'll work for all. And I think it will mean we're also better prepared for future pandemics.
Thank you. And Julia?
Thank you. I can only echo what has been said. I would remind what we learned from the early AIDS epidemic. Public health and human rights is still key to remember that, and stress the need for having universal access to health as the key, the cornerstone for everything we do. Thank you very much.
Thank you. And Joris, finally, your key takeaway and one key policy recommendation.
Thank you so much. Using the actuality of global health to push for SRHR and HIV/AIDS in the policies, and that counts both for funding as well as political support. There's all needs for this. Both funding and political support are under pressure. We saw that also last year at the high-level meeting on AIDS. Considering funding, we strongly recommend a focus on key populations, focus on community-led organizations, and keep in mind the importance of UNAIDS and civil society.
Thank you. And I'll move on to Philip. May I ask you for a one-liner? What will you take with you from this discussion today? And how will you facilitate follow-up to this?
Thank you. Well, first, I think my main take-home message, and for me and for my colleagues, because as you well understand, we are many services involved here. What I think important is to note, because I've heard also very positive elements along this debate, and I think that, so I'll take home that there are notable progresses, but that there is still, as in many health areas, more to be done. And this including at the EU level. And for me, this will be certainly ensured in the framework of the global health strategy we are working on.
Thank you, Philip. And I would like to thank all of you for this very lively and thought-provoking discussion today. I thank the speakers for their passionate interventions and the co-organizers for their great work. I also would like to thank Anton, who joined us to give us the perspective of those on the ground in Ukraine, and you will definitely continue to have our support. I wish to thank the Czech Presidency of the Council of the European Union for hosting this very important dialogue. And in order to conclude, let us give the floor back to Mr. Jędrzej Woboryl for the closing remarks to this event today.
Thank you all for your passionate involvement and finding the best solutions and fighting, or I don't like the word fighting, but trying to really work hard on changes. I would like to say that, as it was mentioned many times, harm reduction is a way forward. For Czech Presidency, for Czech Republic, it's not only a type of intervention. We see it as the main approach of the policy, because on the other side is abstinence. Abstinence is not realistic, and the idea of the world free of drugs didn't bring what it promised. So minimizing harms and risks is probably go forward overly in the drugs policy. Would like to invite you all who can have any influence to support our effort on finalizing the Council conclusion during our presidency, as the Council conclusion concentrate exactly on this particular topic, which is human rights in drug policies and decriminalizing drug users, if I'm simplifying it. I would say worries remains, not only because of the funding. As Jean-Luc mentioned, we have some space in the conventions to do the changes such as Portugal or Czech Republic. But the main actors where the HIV is the biggest problem remain in the opposition of any kind of modern policies. And I would say, as the conventions have the space, they are also the biggest obstacle. And I know this is not easy to express, but I think it's important to target it and address it and speak about it. And I would like to say I'm looking forward to EU being strong, standing globally, not internally, but globally behind vulnerable groups, making it clear that people who use drugs should not be not only criminalized, but they should not be penalized at all. And so we can lift the stigma and resolve not only issues such as HIV, but many other issues around the drug use. Thank you for this event, and hope this will not be only words, but we will take more actions. And as I can see, all of you here are ready. So I'm glad to see so many people to be ready.
Thank you, Jandrik, and I'd like to thank all of you who have participated and who have come to this interesting discussion today. We will surely continue to have more discussions of this kind, and I urge everyone to keep in contact with all of the participants today and the organizers for future events. Thank you, and I wish you all a very good afternoon.